advance. That's long. All right, so the first one tells you to verify the client's history and verify there's no contraindications, such as, first off, nosebleeds. Why? Because we're gonna put the tube through the patient's nose. If they have really bad nosebleeds normally, that would kind of help, but like the possibility of giving them a nosebleed is kind of high. What if we can't stop it? Like they have a history that they can't get nosebleeds that are stopped. Nasal polyps. So we're looking to see, we want to know, are there little pouches of tissue that are going to make it difficult for us to pass that tube through the patient's nose. The other one, chronic sinus infections. People that have chronic sinus infections, sometimes those nasal passages are swollen, again, making it difficult for us to pass the tube because something on the inside may make that passage hard to go through. Orofacial or sinus surgeries. Again, if somebody had a nose job, something happened, it might be difficult for us. The anatomy might not be the same anymore internally that we can't see. Aspiration. Is our patient at risk for aspiration? Will they aspirate if they're not able, if they get this tube? If they're at high aspiration risk, most likely they're going to be, they can't protect their airway. So we're gonna have to put a breathing tube in, and then we would put an oral gastric tube. We would take the same tube and just slide it in the mouth right down into the stomach. And then anticoagulation therapy, meaning if our patient is on a blood thinner, blood thinners make it easier to bleed. The nose is really vascular, so if we're hitting around on places in the nose, don't be surprised if they start having a really bad nosebleed. Then we want to assess the client's level of consciousness and ability to follow directions. Again, can they swallow? Will they be, if they start to feel like they need to puke, could they protect their airway? We're looking for those kinds of things. Then it tells you to gather all these supplies. So they'll all be sitting out for you, every single thing that you need in front of you. Then we knock, introduce ourselves to patient identifiers. She does not have a wristband on, so we'll just pretend. It's like Judy Smith, 10/2/1963. Ask them their allergies. We're here today to put an NG tube in. We're going to give you some medications and we're going to remove your tube. So that's what we're doing today. The first one tells you to develop a hand signal for the client if they're in distress. So a peace sign, like one finger, all 5 fingers together like a stop sign. Because if our patient in real life is in distress, they're doing a lot of this when you're trying to put it in because they don't want it in. Once you start to put it in, they don't want it. So does this mean that I can't breathe, or does this mean you don't like? I don't know what that means. So we need to make a conscious effort to have a hand signal that they can tell us, I feel like I can't breathe. That's really what that's for. Next, we're gonna turn on the suction device. So suction, I'm too far away, is this one right here. It's a vacuum. So this vacuum should be in the room. As you can see, the vacuum has like different levels: green, yellow, orange, red. Green is where we're going to suction on low intermittent suction for an NG tube. It should go from 0 up to 80, back down. Yellow, there's a little bit more pressure, and red is if you took your hand to your vacuum and you could like feel it sucking your skin. That's what that's doing. It is sucking. Do you want something in your intestines sucking at, no, because guess what's gonna happen? It sits there and sucks. It will eventually perforate wherever it is in, usually your stomach. I had a resident once tell me that they wanted it on high suction continuously, and I said, no, sir, that's not happening. We always do it in the green, and that's why the green is there. So even those other things, when you see other things, if you've ever used a vacuum before, it's too high, that's why. So this vacuum should always be in the wall. And then we have this top tube that goes into the bottom of it, and it should always be to a canister. Why? Because we want the stuff to go into the canister, right? So sometimes they have this, and then a lot of places they'll have like an insert in it, so you could take the insert out and get, not this actual hard one. It's like a, I don't know how to describe it. It's like a soft plastic that you put on the inside. I always think of it as like a crock pot with a crock pot liner, like you're doing too thick because you just want to protect it. On the side, there should always be numbers And usually if this patient was getting decompression, we would put a piece of tape down here and we would mark the levels until it got higher. And why we're doing this, because we're seeing how much is coming out of the stomach. Does that make sense? Then there should be a tube off of it that would go to the patient. Because we're not gonna hook our patient directly up to the vacuum, we need some space. I would suggest in real life, we normally put like 2 or 3 of these so our patient can like move around. This is like your patient can only walk this far from the vacuum, like around the whole circle, like a radius around the bed. If they needed to go to the bathroom, like we can keep them on the vacuum, we just need more of the tubings. So we wanna turn this on. So when we turn it on, if we were to hit it to regular suction, just like your vacuum, we could just feel the end and feel that it's sucking. Great, beautiful. But in real life, I would put one of the yank hours, one of the mouth suctions, like the dentist. Think of it like the dentist. So we could get any saliva, or if our patient starts to puke, we could start vacuuming up some puke that's coming. So our thing is on and we're ready to go. Then we want to put on, we want to make sure they're in high, I already have her in high Fowlers. She'll just tell me. I would make sure my patient is in high Fowlers. This bed is a to-do. So just leave her this way. That's why I had it for my students yesterday. We always want to stay on the same side of insertion. So we're going to be putting it on one side. We want to stand on that side. Offer them to blow their nose. That's why the tissues are over here. So offer them a tissue to blow their nose. Again, if you have stuff in your sinuses, the last thing you want to do is have anybody take any of that mucus and put it through the tube and put it through. Plus, if there's stuff in there, they still feel congested. It's really hard for them to blow their nose once the tube is in there. So we did that. The next one is to place the towel on top of the client's chest. So the reason we're doing that is to protect our client in case they throw up, right? In real life, I would put chucks. Probably chucks all the way down, maybe off the side of the bed. Or if our patient's gonna puke, they're gonna puke, which that goes with the next one. Give your patient the emesis basin. Okay, again, who's throwing up in this? Nobody. We're spitting mouthwash in here, brushing our teeth. Nobody's throwing up in this. Bath basin or the blue bags. Like I always offer people, again, the suction, I usually have the thing on so I can, they're gonna puke, they're gonna puke. Now we're gonna put gloves on. We're gonna put our gloves on, and then we are going to grab the pen light that's on the table. What we're looking for, again, they have a deviated septum. Is there like a hole through the middle of their nose? Do they have any irritation? Did they try to put a tube in the emergency room and one side is super swollen and you could see that it was like, you can see sometimes cuts or something, like that's probably not the side. We have 2 nostrils. Maybe we want to go on the other one. Again, do we see those polyps? Or is there an actual obstruction where like maybe, and people do, if you look in their nose, maybe like one side of their nair kind of like caves in a little, and they already say like, I have a hard time breathing through my nose because of just my anatomy. So we've looked. The next one we're gonna do is test the gag reflex. So we have our tongue blade, and we're gonna go in here and we're gonna actually make them gag, because again, if they can't gag and they aspirate, then we don't want them to aspirate while we're putting in the tube. Big problems. Now we have aspirate in the lungs, our patient is probably not doing so hot. Now we're gonna take our tube. Our tube should have measurements on it. We don't want, there are some tubes in here that have no measurements, which is fine. I think I'm gonna take this one home because I need to get, there's like just so much tape on it for my students yesterday. So measurements. What we're gonna do is measure the tube. Tip of the nose to the earlobe, down to the xiphoid process or the bottom of the sternum. Okay, so I measure it. Is this where my stomach is? Is my stomach right here? No, so in real life we'll go a couple inches. So it's in the stomach. On her though, you can't. Like there's a fake stomach in here and it's like this big. So just nose, earlobe, and like right at the bottom of like the boobs and the sternum. So we're gonna mark this. Somebody already has a piece of tape here and it's actually marked in the wrong spot. So we're gonna mark it. We'll say it's at, this measurement is 52 centimeters, roughly. What we're gonna do, these extra large gloves are not working out right now. I'm gonna take a piece of tape. Normally we take a surgical marker to mark it because we don't, who wants a piece of tape hanging out their nose? We're gonna put it right here with the tape marking the number and then going towards the numbers that are gonna stay out of the patient. So the number that's gonna go in is where the tape starts and where the numbers aren't. And we're just gonna make a little flag. Then we're gonna take this blue and white cap and we're gonna put it on here. Why? Because when this tube goes in, we don't want stomach contents shooting out the bottom of the tube and all over our patient or all over ourselves. So clear to white, blue to blue. You want to make a little loop. This little, can you see it kind of on the white one? There's like a little hole. That's a vent. That's not actually the tube. It's a vent, again, for gas that comes out. We don't want a tube. We don't want this like blocking this, because then what? Besides your patient attempting to try to burp, there's no gas. It's all staying inside. So we have that attached to that. And then it says lubricate in quotation marks. We're going to pretend to lubricate because they don't want you guys using a bunch of lubricant on the mannequins. I'm just gonna use a tiny bit because it's probably dry from yesterday. I'm gonna use just a itty bitty. There, just a tiny. Tells your client put their head back. So we're getting more of a direct shot. What we're doing is we're trying to go from the nose to the back of the throat. So by having them tip their head up, we're kind of getting a more direct shot. And then it tells you to continue to pass the tube if there's no resistance. If resistance is met, we could rotate. So what that means is when we stick this in, if we feel that there's resistance right here, we could twist it. Sometimes we need to twist as we're putting it in to help. And then we're gonna go till we get to the back of the nasopharynx, meaning the back of the gag reflex. You'll know. Your patient's eyes will get big. They'll probably start to water. You'll hear them, they're gagging. Just pull it. It says withdraw a little, meaning just like a tiny bit and just wait. In real life, we wanna wait. I wanna give them a breather, collect their thoughts of what just happened, because it could be traumatic to get that in. From there, it tells you to give your patient a glass of water. The reason why is because they think in the video that it's gonna help your patient get the tube down. In real life, again, remember, wet on the inside. If they just swallow, the tube will go down. We dry swallow all the time, probably as you're standing here. You just tell them to pretend to swallow. This water though, if they're getting this tube from gastric decompression, they're NPO, they are not getting any water anymore. This is kind of a false sense. Plus any water that they get that they think is helping them, we're just gonna suck right back up the tube. The other thing is people focus, and I've watched people, I've say fine, whatever, give them a glass of water. They go like this, and then they start to shake. And then what happens? So they start to crush the cup, and either when they get to these, because they're styrofoam, it either water fall down, or I've had it pop up in there like a fountain. Because nobody gives anybody that much water to swallow. They give them the full 360, like the whole cup is water. It's just a gigantic mess. I always just say, don't use it, but at this time you could say, I could give my patient a glass of water. And then we're just going to, it tells them in the video at ITI, it says, put their chin down. Okay, when you do this, how much room is your hand going for this person? Not a lot versus here. You have more room. So I just say, just stick the tube in, and we're just gonna keep advancing it till we get to our flag. We're at our flag. We're going to temporarily anchor this because we need both of our hands. In real life, in a real person, this will start sliding out. It won't in her. But in real life, we're, again, slippery on the inside, it will just start falling out. So, temporarily anchor it. Now we can use both of our hands. What we want to do is use the pen light to see, is the tube coiled inside somebody's mouth? You're probably not going to get to 54 or 52 centimeters with it coiled. It will probably cough and the tube will like come out their mouth. I always say it's like a snake popping out. It will come right out. What you have to do is pull it back till you get to that gag reflex again and reinsert it. All of this is clean, none of this is sterile. So now we're going to take our 60 cc syringe, this large one, and we're going to put it on the end of this tube, and we're going to put it on the clear side, and we are going to pull back 10 to 20 cc's of gastric contents. This is how we're making sure that the tube is inside the stomach. We used to x-ray, we used to put air in and listen with the stethoscope. We don't do that anymore. So we're gonna put this on, and then we're gonna take our medicine cup and we would put it in there. Then we would take our pH strip and we wanna dip it in there. And acid is going to be 0 to 4, the red to orange. For higher, we're in the small bowel. That's maybe not where they want the tube. Once we've done that, normally these are water containers. We would take 20 cc's of water and we want to flush the tube. That's really all I was telling you. We would just take this off, put this on, put the water in, and then reconnect the tube for now. Now we want to anchor the tube using the PANTS method. So we're going to take our tape, about 2.5, 3 inches. Do you want a longer piece of tape? We're going to cut it down the middle. So we're making like a little pair of pants. We got a top and 2 legs. The top part, or the waist part, is going to go on top of the bridge of the nose. The legs, we're going to take one and wrap it around completely. Take the other one, wrap it around, but you don't want to obstruct the other side of the nose. Do you see that? How we're trying to keep a little obstruction. Then we're going to take the temporary anchor out. You could just take this piece of tape and we want to put it towards the bottom. The reason why we want to put it towards the bottom is because we don't want this tube so tight that the person can't move their head and they feel like they're pulling it out. So we're going to put it at the bottom. We're going to take our safety pin. We're going to put it through the flag, and then we're going to pin it to the gown, up near the top. Then we could hook it to the suction. We could get rid of our supplies. We're going to take off the towel, take the basin, clean everything up, and the head cannot go less than 30 degrees. The head goes less than 30 degrees, our patient could aspirate any of those stomach contents or whatever. So that's part 1. Now part 2, we have exactly the same as the other medication ones, because now we have to give them medications. We need to review the client's past medical history. We need to review their allergies. We need to look at their vitals, including blood pressure, glucose, heart rate. We are going to make sure we have no interruptions, that we leave all the medications inside the wrappers, that we're not distracted. We are going to take our first med and we're going to use the 6 rates, person, drug, dose, timer out, documentation, and our next drug will be digoxin. So the one that I crossed off on the other MAR, but it's the next one on your practice one. So digoxin. So we're gonna look, and we have digoxin. This one says 0.25 milligrams, 250 micrograms. That is the same thing. They just want to see that you know the different conversions. It's really for the ADN people because you guys haven't gotten that far, but that's what that is. Hold of apical pulse is less than 65, so we need to go back and check what is our pulse. So the pulse on this one is 71. We're going to give it by mouth, which is true. We're going to give it through the tube though, and we're going to give it daily now. Our expiration is 12 of 2029, and that's great. So we have that. Then again, we're going to compare for our second check. Then we're going to perform hand hygiene. We're going to look at our patient's name band. I just don't have one sitting here. We'll just pretend that one says the same. So we're going to look at our name band. All right. Dale Booth, 3/22/1953. Dale Booth, 3/22/1953. Dale, do you have any allergies? Yes to pineapple and sulfa. Okay, great. I'm here today to give you your digoxin. Do you have any questions? You could explain it at this time, what digoxin is. We're gonna do our third check. So we have digoxin, 0.25 milligrams, 250 micrograms. Hold of the apical pulse is less than 65. The pulse is 71, so we're good to give it. It's PO. I do have some pills. It's due now, and the expiration is 12 of 2029. Great. So then it tells you number 51, collect the pill crusher. So we need the pill crusher. We are going to open the pill crusher, and we are going to take one pill from the package. We have our one pill. We are going to twist it to crush the pill. I usually untwist a little again, shake it, twist it again so we make sure that the pill is completely crushed. And then you can look and see that it's a nice powder. We're gonna take that powder and we're gonna put it in a medicine cup. Just tap the side. And then it just tells you repeat the process for each medication. Now we wanna make sure our patient is, again, up in that high Fowler's. We wanna make sure that they're completely up. And towels over their chest. We need to verify that the tube is in the correct spot. So we're gonna take our 60cc syringe. We're gonna attach it to the clear end. And we're gonna pull back. So this time you guys actually get contents. Our 10 to 20 of fluid. I forgot to get a cap for this one. We're gonna put our stomach contents in there. We would verify with the pH strip that we're in the stomach. We're good to go. Then it tells you to draw up the water. Drop some water. We're gonna just clear the tube. Can you see how it's bubbling in the container? So we cleared our tube. I would put my cap back on. All right, so now it tells you we're gonna mix the medication. It does say 20. You can just do like 10. It's gonna be a lot of water if we do. Like the water, like this isn't gonna hold all 20 in this medicine cup. So we need just a little bit of water. You'll see me pull out the end when you're at this part because I just don't want to contaminate it all. You're gonna take the end of the 60cc. We're gonna mix it till our pill is dissolved. You're then going to draw it up. You may need to put it on an angle to get all of it in there. So all the medication's in there. Uncap our tube. We're just gonna push it slowly through there. Okay. Cap it. Take like 10 to 20 water. Flush it through. Okay, nice and slow. Then we repeat this process, but we want to wait 30 minutes to restart any feeding or the vacuum afterwards. That's the big thing. All right, now we have to go take the tube out. All right, then it tells you to gather your supplies. Our supplies for this are just the emesis basin and the towel. So again, we want to make sure that we have the right patient, what their allergies are. The big thing, if you forget to identify them, it's okay because we've already done it once. I'm already editing this one to take that out. The big thing, tell them they may feel some discomfort. That tube is coming up, it has stomach acid on it, so, excuse me, they may feel some heartburn or stuff in the back of their throat, you know, like, or in their nose when it's coming out. We're gonna perform hand hygiene and put on our gloves. Again, just another set of gloves. Tells you to, again, put the clean towel over their chest. Make sure they're in semi-Fowlers or high Fowlers to prevent any aspiration. Again, in case they feel like they might throw up, we want to give them the emesis basin. We're going to start disconnecting everything. So if this vacuum was connected, we would disconnect it and then connect our tube together so it's anchored off. We're going to unpin it from the gown. We're going to take the tape off the nose. Still want to hold on to it because it could slide out. Then we're going to tell our patient to take a deep breath and hold it. They have to hold it this time. Again, we don't want them to aspirate any of that stomach contents that could be on that tube. It tells you to pull the tube out gently, wrapping it end over end and avoiding splashing. So what we're going to do is we normally take the bottom of the tube and you wrap it around your hand, and I'm just going to keep wrapping it as I pull it out. Does that make sense? So I'll tell them, take a deep breath in, blow out your candles, take a deep breath in, and when they take that deep breath in, I'm just gonna pull it as I wrap it around my other hand. Why we do that is because if I didn't, and I took this, the end of the tube has stuff on it usually, and it will go everywhere. So we wanna check to make sure the tip is intact. Again, remember this isn't a stomach acid. It really could eat away the plastic. I've had some where they're like hanging on by a thread when we've pulled them out. What if the tip is missing? Is it in the stomach? Is it in the esophagus? Back of the throat? Is it in the nose where they could then inhale it? Like that's why it's gonna be really important to look. Again, we're gonna provide them some oral care, get rid of everything, put them in a comfortable position, give them their call light, remove our gloves, and leave. Does that